Welcome, listener, to another deep dive. Today, we're peeling back the layers on how hospital teams really operate. We often assume, rigid protocols, but what happens when chaos hits and resources get stretched thin?
Exactly. And we're diving into a really fascinating new ethnographic study today. It looks beyond just preventing errors, what some people call a safety eye mindset. It tries to understand how healthcare actually succeeds day in, day out.
Ah, so moving from what goes wrong to how things actually work.
Precisely. It's about recognizing that the plan, the work as imagined, often looks very different from the work as done. And these on-the-fly adjustments, these adaptations, are absolutely crucial, especially during disruptions. They maintain safety and quality.
Okay. So our mission today is to unpack how these different kinds of hospital teams handle those challenges. This study, it was done in a big London hospital, right? Sounds like it has some surprising insights into that everyday flexibility.
It really does. Shows how patient care keeps flowing.
Right, let's get into it then. What exactly are these misalignments and adaptations in, practical terms?
Good question. So misalignments are basically when demand and capacity just don't line up. Could be anything, really. Equipment shortages are a big one. Unexpected staff calling in sick. Communication glitches. Even the physical space not being quite right.
Okay, so the system is stressed, and adaptations are the fix.
Adaptations are the dynamic adjustments teams make just to keep things running. The study found three main kinds. There's extra role performance that's basically doing tasks outside your normal job description.
Stepping up.
Exactly. Then resource redistribution, like borrowing equipment from another ward or even borrowing staff. And finally, process adaptations.
Yeah.
That means changing who does a task or how they do it or when it gets done.
Got it. So it's clear these adaptations are vital, but what really struck me was the finding that not all teams adapt the same way. The study found different team structures handle this differently.
That's the core finding, really. And this is where it gets super interesting. They identified four distinct types of teams. First, you have structural and satellite teams. Think of stable ward units, or maybe mobile surgical teams.
Okay, teams that generally work together regularly.
Right. And they generally had fewer misalignments to deal with, and they adapted pretty effectively when they did. Because they have stable membership, they could coordinate well. They mostly use those how and when process adaptations.
Can you give an example?
Sure. One structural team, when the hospital intranet went down, they just used Google to look up a policy, a workaround. Or a satellite team might book a patient straight into interventional radiology if the ultrasound service was delayed, bypassing the bottleneck.
So finding clever detours, like you said, managing within their own team.
Mostly, yes. But then you have the hybrid teams. Their experience was quite different. Think of the acute assessment unit, maybe. They have a mix of permanent staff and temporary or agency staff.
Ah, I can see how that might be tricky.
It was. They were found to be the most vulnerable to misalignments. The temporary folks often didn't have that local knowledge, which meant the stable senior staff, like the ward matron, a senior nurse manager, had to do a lot of that extra role performance.
Covering for the gaps in knowledge.
Exactly. Filling knowledge gaps, fixing issues.
Yeah.
But it meant the matrons often couldn't finish their own work. They'd end up staying late, and communication problems were rife. Sometimes patients were discharged without the right medications or care packages sorted.
Wow, that's serious.
Very. And then the last type, coordinating teams. These are often office-based, managing hospital-wide stuff like bed allocation.
The logistics hub, kind of?
Sort of, yeah.
Hmm.
Their challenge was dealing with conflicting priorities, constantly changing information coming from all the different wards. So they often resorted to extra role performance, too. But in their case, it meant physically going to the wards to check information.
Leaving the office to verify things firsthand.
Right, which, works, you get the right info, but it's incredibly time-consuming. It could make them slow to respond to other urgent tasks piling up.
So what I'm hearing is that these adaptations, these clever fixes, they're essential, but they often come at a cost. Solving one problem might create another one somewhere else in the system.
Absolutely. That's a key takeaway. These adaptations, vital as they are, frequently led to heavier workloads, delays, even tension between teams. The study mentioned things like staff leaving, slightly aggressive notes on shared computers to stop others borrowing them.
Huh. Really? Like digital territory marking.
Pretty much.
Yeah.
It just highlights how these locally adaptive solutions, things that work for one team right now, can sometimes become globally maladaptive, bad for the whole hospital system.
That really makes you think. And it brings up a big question, maybe for you listening. If adaptation is so vital, how can healthcare systems be designed to actually support it better, not just stamp it out?
That's the million-dollar question, isn't it? This study really emphasizes that designing for adaptation, supporting these teams, is crucial. It means thinking about team structure, their goals, even where they're located physically. Interventions could mean providing enough dedicated equipment for everyone, so less borrowing is needed, having proper meeting spaces, and, importantly, designing processes that help temporary staff get up to speed quickly, understand their role, and contribute effectively without overloading the permanent team.
So creating environments that embrace adaptive capacity rather than just demanding strict compliance with rules that might not fit the reality on the ground.
Exactly. Support the flexibility, don't just enforce the imagined plan.
So listener, you've heard how the real heartbeat of a hospital isn't just following protocols. It's this constant on-the-fly improvisation, a dynamic dance between what's needed and what's available, with each team figuring out its own steps.
And understanding these different ways teams adapt and their hidden costs is just vital if we want to design safer, more resilient healthcare systems. It's about really valuing and supporting the work is done, the work that truly keeps patients safe.
So maybe some food for thought for you. Where in your work, or even just your daily life, do you see that work is imagined clashing with the work is done? How do you or your team adapt in those moments? And crucially, what are the hidden costs, the trade-offs of those adaptations? Something to mull over until our next deep dive.